Dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And to present today's topic, I welcome Dr. Jaimanti Bakshi. Welcome, ma'am. Over to you.
Thank you, sir. Thank you so much. Good evening, everyone. So today I will be speaking on oropharyngeal cancers, overview and management. So what is oropharynx and what are oropharyngeal cancers? I will give a brief introduction. Oropharynx is at the crossroads between respiratory and digestive tracts. Malignant lesions in this area alter swallowing, speech and breathing. So treatment plan should focus on the anticipated functional outcome in addition to the disease clearance. Neoplasms of the oropharynx are uncommon and majority of the tumors encountered in this area are malignant in nature. Now coming to the anatomy of oropharynx. So it extends from superior to inferior. Superiorly, it is bounded by hard palate and inferior extent is up to hyoid bone. For the purposes of tumor classification, it has been described as having anterior wall, posterior wall, lateral wall, and roof. So here you can see the extent of oropharynx, superiorly from hard palate and inferiorly it goes up to the hyoid bone. Anteriorly it communicates with the oral cavity. And here in this picture you can see this is posterior wall of the oropharynx. This is uvula and soft palate. They form the superior boundary. Palatine tonsils, anterior and posterior tonsillar pillars are also part of the oropharynx. Glossotonsillar sulcus and retromolar trigone. These are the circumvallate papillae, and part of the tongue which is posterior to the circumvallate papillae comes in the oropharynx and anterior part comes in the oral cavity. So contents of the oropharynx include base of tongue, vallicula, inferior or anterior surface of the soft palate, uvula, anterior and posterior tonsillar pillars, glossotonsillar sulci, the pharyngeal tonsils, and lateral and posterior pharyngeal walls. So lateral wall of the oropharynx gains more attention because tonsils are located in the lateral wall and most of the tumors of the oropharynx arise in this area. So lateral wall of the oropharynx forms the lateral boundaries of tonsillar fossa, which are composed from within outward by pharyngobasilar fascia. Here you can see pharyngobasilar fascia as the innermost layer. Then comes the superior constrictor and palatopharyngeus muscles, buccopharyngeal fascia, and styloglossus muscle and glossopharyngeal nerve in the lower part. Anterior wall of the oropharynx is deficient above and it communicates with the oral cavity, and below it is formed by base of tongue, posterior to circumvallate papilla. These are the circumvallate papilla and this is base of tongue. Lingual tonsils form content of the base of tongue, and there are vallicula on each side of the base of tongue. They are separated by median glossoepiglottic fold. This is median glossoepiglottic fold. These are lateral glossoepiglottic folds. So these are vallicula. Posterior wall of the oropharynx is formed by posterior pharyngeal wall, and here we can see part of the posterior pharyngeal wall. So what is the lymphatic drainage for oropharynx? Tumors of the oropharynx drain into levels 2, 3, 4 commonly, and some of them can drain into retropharyngeal lymph nodes like tumors arising from posterior pharyngeal wall and palatine tonsil. Bilateral drainage can occur in the tumors arising from tongue base, soft palate, posterior pharyngeal wall, because these are the midline structures. So if the tumor is arising in these areas, so those patients can have bilateral lymphatic drainage. Probability of lymphatic metastasis is related to the size and location of the primary tumor within the oropharynx. Now coming to the nerve supply of the oropharynx, sensory supply is by glossopharyngeal nerve, motor supply by vagus nerve, base of tongue is supplied by hypoglossal nerve, and it provides the motor supply to base of tongue muscles. Soft palate has motor and sensory supply by the trigeminal nerve. Vagus and glossopharyngeal nerves give auricular and tympanic branches, which can lead to referred otalgia in these patients. Now coming to the epidemiology of oropharyngeal cancers. Oropharyngeal cancers account for 10 to 12% of all head and neck malignancies worldwide. Incidence is high in developing countries, and it is 4.8 per 1 lakh population. There is increase in the HPV-associated oropharyngeal cancers recently, and it is more in the Western countries as compared to India. Peak incidence is seen in 6th or 7th decade of life, and it is more common in men with a ratio of 4:1. The risk factors for oropharyngeal cancers include patient-related risk factors are age and gender. Predisposition in males, especially those who are smokers and older than 50 years of age, has been seen. Lifestyle factors like cigarette smoking, alcohol, tobacco and alcohol. All these are lifestyle factors which can increase the risk of oropharyngeal cancers. And it has been found that tobacco and alcohol have synergistic effect for the oropharyngeal cancer. HPV-associated oropharyngeal cancer is an entirely different entity, and incidence of this HPV-associated oropharyngeal cancer is increasing recently. So what is HPV? HPV is human papillomavirus. It is a circular DNA, double-stranded DNA virus. It was found to be associated with cervical cancer in 1983. Approximately 150 types of HPV have been identified, and HPV-16 is the most common type associated with more than 90% of oropharyngeal cancers. So this is the genome of human papillomavirus, HPV-16 genome, and here we can see the various oncoproteins and various genes which code for this virus. So HPV genome encodes 3 oncoproteins. These are E5, E6 and E7. These are the oncoproteins. 2 regulatory genes, E1, E2, and 2 capsid genes, L1, L2. Oncogenesis is primarily mediated by E6, E7 proteins. HPV E6 complexes promote ubiquitin-mediated destruction of p53. Loss of cellular p53 function results in dysregulation of the G1S and G2M checkpoints in the cell cycle. E7 is believed to be the major transforming oncogene during early carcinogenesis, with E6 functioning later. So what are the clinical characteristics of HPV-associated oropharyngeal cancer? So clinical characteristics of HPV-associated oropharyngeal cancers are slightly different from the HPV non-associated oropharyngeal cancer, and these are more commonly to occur in men than women with a ratio of 3:1. Most of these patients are younger in age as compared to the non-HPV-associated oropharyngeal cancer. 80% will not have a history of smoking, and it is diagnosed in individuals who are 5 to 10 years younger than HPV unassociated oropharyngeal cancers. P16 IST testing is an accurate surrogate for HPV infection. If we see the response of HPV-associated cancers, so it has been found that patients with HPV-associated oropharyngeal cancers have significantly better outcomes compared to the HPV-unassociated oropharyngeal tumors. In RTOG 0129 trial, HPV status was independently associated with improved outcomes, and 3-year overall survival was found to be 82% in HPV positive patients compared to the 54% in HPV negative patients. Now coming to the pathology of oropharyngeal cancers, most of the oropharyngeal cancers are squamous cell carcinoma and accounts for 90% of the oropharyngeal cancers. Minor salivary gland carcinomas can also arise in the oropharynx, followed by lymphoma, plasmacytoma, sarcoma, and melanoma as rare tumors. The routes of spread of oropharyngeal cancers are, it can spread locally from the oropharynx, it can go into the vallecula and larynx, it can go into parapharyngeal area, into the pterygoid muscle and plates, extending into the nasopharynx and oral cavity. And it can involve oral tongue and retromolar trigone. Perineural invasion, especially along the branches of 5th and 7th cranial nerves, can occur. Oropharyngeal cancer can also spread through the lymph nodes, and lymph node involvement is seen in 55% of oropharyngeal cancers. Most common location for the lymph node metastasis is ipsilateral level 2 lymph nodes. Typical order of metastatic progression is systematic from upper jugular chain superiorly, that is level 1 to 2, as first echelon nodes, to mid cervical level 3, and then to the lower cervical nodes level 4 inferiorly. Retropharyngeal nodes represent a nodal drainage for oropharyngeal cancers. Contralateral nodes are at risk for tumors near midline or with advanced T and N stages of the disease. Oropharyngeal cancer can have distant metastasis in patients with advanced stage disease. The most common site of hematogenous metastasis is lung. It can be seen in 20% of the cases. And other sites of the distant metastasis can be liver and skeleton. However, primary lung cancer should always be excluded in these patients who present with lung metastasis. Coming to the clinical features of oropharyngeal cancers, it can have various clinical presentations. It can present as asymptomatic neck node or mass in a patient, or can present with pain, dysphagia, otalgia, foreign body sensation in the throat, hemoptysis, weight loss, voice changes. So in these pictures, we can see that this patient is having pain here in the neck, and he is having otalgia as one of the presenting features of oropharyngeal cancer. So this picture explains the mechanism of otalgia in patients with oropharyngeal cancers. So as you know, oropharynx is supplied by the glossopharyngeal nerve. So glossopharyngeal nerve gives tympanic nerve of Jacobson, and it forms tympanic plexus on the promontory. And drainage, if the tumor is arising from posterior 1/3 of the tongue, tonsillar fossa, pillars, or inferior nasopharynx, or parapharyngeal space, or retropharyngeal space. So all these areas are supplied by the pharyngeal, lingual, and tonsillar branches of 9th cranial nerve. So sensations can travel from here, from these areas, and they can affect the tympanic nerve of Jacobson and can lead to otalgia. Now coming to the oropharyngeal cancer staging. So staging is done according to the AJCC staging system, and it is TNM staging system. For T or tumor stage, TX is primary site, cannot be evaluated. T0 is no evidence of carcinoma. TIS is carcinoma in situ. T1 is tumor less than 2 centimeters in greatest dimension. T2 is the tumor 2 to 4 centimeters in greatest dimensions. T3, tumor more than 4 centimeters in greatest dimension. T4A, when tumor invades the larynx, deep or extrinsic muscles of the tongue, medial pterygoid, hard palate, or mandible. T4B is the tumor which invades the lateral pterygoid plates, lateral nasopharynx, skull base, or carotid. Here we can see in these pictures, here the oropharyngeal cancer is extending into the larynx and vallecula, and it is involving the deep muscles of the tongue. Medial pterygoid is also involved. We can see extension into the hard palate And in this picture here, the tumor is involving lateral wall of the nasopharynx. So it is advanced oropharyngeal cancer. It is involving pterygoid plates also and reaching up to the skull base. So T4B oropharyngeal cancer is staged when there is involvement of either the lateral pterygoid muscle, or if the pterygoid plates are eroded, or if the lateral wall of nasopharynx is involved, and if the carotid artery is encased. In this picture, we can see encasement of the carotid artery, and here the tumor is causing involvement of the foramen ovale at skull base. End staging is as follows. Annex regional lymph nodes cannot be assessed. N0 no regional lymph node metastasis. N1 is single ipsilateral node less than 3 centimeter. N2 is single ipsilateral node more than 3 centimeter but less than 6 centimeter. N2B multiple ipsilateral nodes all less than 6 centimeters. N2C bilateral or contralateral nodal involvement but none more than 6 centimeters in size. N3 is nodal involvement more than 6 centimeters. M stands for distant metastasis. MX when distant metastasis cannot be evaluated. M0 is no distant metastasis, and M1 is distant metastasis present. So how should be the diagnostic workup of these patients who present with oropharyngeal cancers? Complete physical examination of the patient should be done, including examination of the oral cavity, oropharynx, and neck. Endoscopic examination is an important part of the examination in these patients, and fiber optic laryngoscopy is done to assess the local extent of the disease in OPD. Evaluation of the upper aerodigestive tract is crucial to evaluate the primary site of the disease and the presence of synchronous primaries in the upper aerodigestive tract. The laboratory tests which should be done in these patients include complete blood count, basic blood biochemistry, hepatic and metabolic panels to rule out the distant mets and to see the nutritional status of the patient before treatment. Testing for HPV in the biopsy specimen should be done, and we should do P16 immunohistochemistry testing. Biopsy should be done under local anesthesia. Tissue from either the primary tumor or neck lymphadenopathy is crucial for pathologic diagnosis. Imaging should be done in the form of contrast enhanced CT from base of skull to T4, and it should include the face and neck. Chest X-ray should be done, ultrasound whole abdomen to rule out distant mets. CECT thorax should be done in patients who have a high risk of lung metastasis, and FDG PET CT scan should be done in patients who have advanced stage of the disease or in patients who have heavy nodal disease. So this is the protocol for CT scan in these patients. The slice thickness should be less than 5 mm so that you can detect the smallest lymph node involved, and even the tumors which are very smaller in size and which are submucosal in location can be picked up by slice thickness less than 5 mm. Pathologically involved lymph nodes are characterized on CT. They will be enlarged and they enhance with contrast and have a necrotic center. Primary tumors appear as contrast enhancing masses, distorting normal anatomic relationships. Whereas ulceration and invasion into the surrounding organs are readily assessed, submucosal spread is often difficult to see on CT. Thoracic CT should be performed routinely in patients with N2 or greater nodal disease and those with advanced primary stage of the disease. Here in this contrast enhanced CT, we can see a tumor at the base of tongue, and we can see it is enhancing as compared to the normal surrounding structures. It is reaching up to the vallecula. It is involving the base of tongue. And we can see bilateral lymph nodes. These are the bilateral enlarged lymph nodes having necrotic centers, and there is heterogeneous enhancement in these lymph nodes. So magnetic resonance imaging or MRI has a great role in treatment planning for carcinoma of the oropharynx. It can be useful imaging tool for oropharyngeal tumors. Squamous cell carcinoma appears as low signal in T1 MRI, corresponding high signal in T2 sequences. ability of MRI to differentiate tumor from soft tissues is particularly useful when determination of the extent of the base of tongue or oral tongue invasion is needed. Additionally, MRI is useful in patients with compromised renal function who are not suitable for CT with contrast. So MRI gives us higher soft tissue details as compared to the CT, and it can differentiate the tumor from the surrounding normal soft tissues. Positron emission tomography alone or with PET-CT is imaging. Incorporating tumor physiology in conjunction with the anatomic information are now routinely recommended for the initial staging of oropharyngeal cancer patients. PET-based imaging can assess not only the local regional burden of the disease, but can also detect and quantify the distant metastasis. It has high sensitivity of 100% and about 60% specificity. As per NCCN guidelines, FDG PET-CT should generally be considered in stage 3, stage 4 disease in all patients. So here we can see the difference in the images. This is conventional CT, and on this CT, extent of the disease is not so obvious, and lymph node involvement is also not so obvious. But on PET-CT, and we can see there is uptake in the areas here and here, and this is the lymph node, which is biopsy positive lymph node, and it is easily picked up on PET-CT as compared to the conventional CT. So what are the treatment modalities for oropharyngeal cancers? Once we have made the diagnosis of oropharyngeal cancer, we have to make the staging before planning treatment, and we have to stage the disease, and treatment planning has to be done according to the disease stage. So they are in the form of surgery, radiotherapy, chemotherapy, and targeted therapy. So for stage 1 and stage 2 tumors, they are considered as early stage disease, whereas stage 3 and 4 non-metastatic are considered locoregionally advanced disease. Early stage tumors are usually well controlled with a single local modality, either radiotherapy or surgery. For locoregionally advanced disease, 2 appropriate treatment strategies are used. Either surgery followed by radiation therapy with or without chemotherapy based on the pathologic risk factors, or radiotherapy usually given with chemotherapy. So what are the various types of surgical procedures which can be done according to the location of the tumor in the nasopharynx? For base of tongue tumors, so tumors arising in the base of tongue pose a diagnostic as well as treatment dilemma to the surgeons, because if you have to treat a tumor at the base of tongue, sometimes you have to do the total glossectomy, you have to do supraglottic laryngectomy along with total glossectomy. So surgical procedure becomes very morbid, and it causes a lot of morbidity to the patient. So surgery plays a limited role in the management of base of tongue tumors, given the inherent morbidity of a near total or total glossectomy, which is required for large hand or midline tumors. For select well-lateralized base of tongue tumors with minimal cervical lymphadenopathy, a partial glossectomy can be performed. Given the high propensity for occult microscopic nodal involvement, bilateral cervical lymph node dissection is often performed for base of tongue tumors. Base of tongue tumors in close proximity to the laryngeal apparatus, such as those arising in the vallecula, often require a supraglottic or total laryngectomy to achieve the adequate margins of resection. So traditional surgical approaches for the base of tongue tumors include midline mandibulotomy, that is splitting the lip mandible and the tongue in midline. Lateral mandibulotomy, dividing the mandible near the angle and approaching the base of tongue from side. Floor drop procedure, that is elevating the inner periosteum of the mandible from angle to angle, which releases the entire floor of mouth and oral tongue into the neck, exposing the base of tongue. So all these traditional surgical procedures have high morbidity, and they require long time for functional restoration after surgery. For tonsil cancer, so what are the surgical modalities available? For small, less than 1 centimeter early stage tonsil cancers confined to the anterior pillar, a wide local excision can achieve adequate tumor-free margins, whereas tumors involving the palatine tonsil often require a radical tonsillectomy. For both these situations, the tonsil is approached transorally with primary closure. Larger tumors with extension into the tongue, into the mandible, into the surrounding tissue often require a composite resection, usually including resection of the tonsil, tonsillar fossa, pillars, a portion of the soft palate, tongue, and mandible. For tumors not adjacent to or not adherent to the mandible, a midline mandibulectomy approach is used. But for tumors which are adherent to the mandible, a partial mandibulectomy is used. Defects are often closed with a myocutaneous flap like pectoralis major myocutaneous flap, which is most commonly used for reconstruction of the defects in the oropharynx and oral cavity. Complications from surgery depend on the extent of the resection, with impairment in swallowing possible by the removal of tongue or soft palate. For soft palate cancers, the surgical resection is rarely recommended as the initial therapy for soft palate tumors. Resection of the soft palate is often associated with significant reflux into the nasopharynx during swallowing, even with the use of custom prosthesis. Additionally, because of the midline location, the primary disease spreads bilaterally to the neck with frequency high and requires elective treatment of the neck. However, when the surgery is performed, tumors are approached transorally and with a full thickness wide local resection is performed for tumors limited to the soft palate. A more extensive composite resection is required if the disease extends to the surrounding structures. Flaps or prostheses are used to preserve the velopharyngeal competence. Nasal speech is often a consequence of resection of the palatal tumors. So what are the surgical modalities which can reduce the morbidity in oropharyngeal cancers? So they are in the form of transoral laser surgery and transoral robotic surgery. So coming to the transoral laser surgery, small cities report favorable outcome for selected patients with stage 1 through stage 4 oropharyngeal tumors treated with transoral laser microsurgery with or without neck dissection, followed by adjuvant radiotherapy or chemotherapy. Positive margin rates are variable from 3 to 24% and appear to vary based on the primary site, being more common in the base of tongue tumors. The complications include postoperative hemorrhage, which can occur in 5% to 10% of patients. Temporary tracheostomy may be required in 17 to 30% of patients, and it may be needed for exposure, airway control, aspiration following extensive resection. High rates of local regional control following this procedure have been reported, primarily for stage 1 and stage 2 patients, which is 87 to 100%. Although for stage 3 and 4 patients, local recurrence is common, that is in 20 to 30% of patients. So the latest treatment modality for oropharyngeal cancers is transoral robotic surgery, which is being done all over the world now, and it requires high expertise. It requires the robotic system, which is not available in all centers, but it is an evolution in the surgery for oropharyngeal cancers. So what is transoral robotic surgery? The use of computer-aided interaction between the surgeon and the patient, commonly referred to as robotic surgery. The most common robotic surgical system, the Da Vinci surgical system, comprised of 3 surgical instruments and a binocular endoscope controlled by the robotic arms and inserted under direct or endoscopic guidance by the surgeon from a patient's side apparatus. The surgeon controls the instruments from a console which is separated from the patient. The operative environment is visualized virtually in a 3D view created by a computer that links the environment provided by the binocular endoscope to the position of the instruments. The surgeon's movements are translated into the micro movements of the robotic instruments. The advantages of this system include motion scaling, which can increase the precision as well as reduce the hand tremor and fatigue. When the system is used for transoral surgeries, the assistant is often positioned by the patient's head. But there are no prospective randomized studies supporting the use of transoral robotic surgery for oropharyngeal tumor resection over conventional surgery until we have some mature multi-institutional series and randomized data are available. The true utility of transoral robotic microsurgery and laser microsurgery and TORS remains unknown, although early results are favorable and associated with shorter hospital stays, the long-term data are needed. Additionally, the standard oncological principles limiting the number of modalities used to minimize treatment-related side effects should be carefully considered prior to widespread adoption of the surgical techniques. So this was all about management of the primary tumor of the oropharynx. Now coming to the neck management. So neck management is one of the important part of the treatment for oropharyngeal cancers, as incidence of metastasis to the neck nodes is high in oropharyngeal cancers. So type of neck dissection, whether comprehensive or selective, is defined according to the preoperative clinical staging, is determined at the discretion of the surgeon, and is based on the initial preoperative staging as follows. For N0 neck, selective neck dissection of at least levels 2 to 4 is sufficient. For N1 to N2A, B and C nodes, selective or comprehensive neck dissection can be done. For N3 nodes, only comprehensive neck dissection has to be done, which includes removal of all lymphatic levels and fibrofatty tissue from level 1 to level 5, with preservation of all three vital structures, including sternocleidomastoid muscle, spinal accessory nerve, and IJB. Now coming to the radiotherapy. Radiotherapy has a great role in the treatment of oropharyngeal cancers. So it can be given in various forms, and it can be given either alone or in combination with chemotherapy. Definitive chemoradiotherapy is the treatment of choice for oropharyngeal cancers. For early stage oropharyngeal cancers, the use of radiation therapy is as a single modality is associated with good outcomes and functional preservation. Patients with locoregionally advanced oropharyngeal cancer, concurrent chemoradiotherapy is the standard treatment. Resection is generally not recommended given the associated surgical morbidity. Chemotherapy used in concurrent settings along with radiotherapy. Recurrent and metastatic tumors require chemotherapy, and it can be given as neoadjuvant chemotherapy before starting the definitive chemoradiotherapy. So various radiotherapy techniques are, it can be given either as two-dimensional planning or 3D planning, or the latest technique is IMRT, which is also known as intensity modulated radiotherapy. This is computer-based radiation treatment planning. In conventional radiotherapy, the fields used are, these are the fields. So, and here we can see the borders and doses for various fields. So initial opposed lateral fields, including the area from base of skull to neck on both sides. So here superiorly it starts at the skull base and inferiorly goes up to the higher bone. And dose delivered is 40 to 45 rays. The second field is off-chord cone down lateral fields for elective areas, which starts at the skull base, and dose delivered is 50 to 54 rays. And third type of field is electron post-neck E-strips, in which dose up to 70 rays can be given for N-positive nodes, and 50 to 54 rays has to be given for N-negative neck. Here we can see the low anterior neck field for carcinoma base of tongue. These are the radiation fields. So you have to cover the area from skull base and go down into the neck. You have to cover the neck also, including levels up to level 4. This is for tonsil. Here we can see the radiation fields for N0 neck. This is N0 neck in patients with carcinoma tonsil. And these are the radiation fields which you have to cover. For N-positive neck, you have to give a higher dose, so you have to cover a wider area. This slide shows the conventional RT films for radiation patients. So here we can see the radiation portals which have been demarcated on the X-ray films. So 3D planning for radiotherapy is the latest evolution in the field of radiation oncology. Patients should undergo simulation, preferably CT-based, to allow for optimal radiotherapy planning. A peripheral IV should be placed prior to simulation so that we can give the contrast agent to the patient, which can delineate the vascular structures and lymph nodes better. Patients are positioned supine, extended head position is preferable. Shoulders should be immobilized or should be pulled down. Care should be taken to ensure that mask on the face is thermoplastic mask on the face is tight and should not allow movement of the nose, chin, or forehead. So the various radiotherapy volumes which have been set by the ISRO 50 are the GTV is gross tumor volume, includes all non-primary and cervical node tumor extension based on the clinical endoscopic imaging findings. Care should be taken to look for the fat standing around the lymph nodes, which indicates extranodal extension of the tumor. CTV or clinical tumor volume, indicating the margin needed to cover microscopic extension, which is not visible on clinical and imaging modalities, is not known. So current RTOG guidelines specify an extension of 0.5 to 1 centimeter from the GTV to cover the microscopic extension of the disease. So here we can see the various IMRT treatment volumes recommended by University of Wisconsin. And here we can, this is the contour on CT planning, GTV, gross tumor volume, primary tumor and involved nodes, and dose of radiation to the GTV should be 60 to 70 grays. For CTV1, that is high risk area, 60 to 66 grays radiation is recommended. For CTV2, intermediate risk areas require 50 to 56 grays, and low risk areas we may give 50 to 54 grays. In this slide, we can see the various, these are the color coded areas, and various radiation doses have been recommended for the different areas. Like here, this is the primary tumor. So it will require a higher dose. Red color wash GTV will require 70 grays. Then blue color wash will require 60 grays, and yellow will require 56 grays. So what is the dose of radiation and fractionation schedules which are used for oropharyngeal cancer? Standard dose is 66 to 70 grays, delivered at the rate of 1.8 to 2 grays per fraction for 6 to 7 weeks, along with concurrent cisplatin, 35 milligram per meter square weekly. This is the standard radiation protocol. The other radiation protocols are hyperfractionation schedule, in which 86.6 grays are given at the rate of 1.2 grays per fraction twice daily in 7 weeks. URTC 22791 recommends hyperfractionated radiotherapy for locoregionally advanced tumors, and they found that it was associated with statistically significant improvements in the locoregional control, and 5-year control was 59% versus 40% with the conventional treatment planning. Additionally, there was a trend towards improved overall survival with the hyperfractionated radiation protocol. The other fractionation regimes include accelerated regime of 66 to 70 grays delivered in 2 grays daily fractions, 6 days a week. Accelerated fractionation with concomitant boost regime delivers 72 grays in 1.8 gray fractions for 14 fractions, and there can be simultaneous integrated boost for early stage T1, T2 lesions of the oropharynx, in which patients treated with bilateral neck radiotherapy, and gross tumor received 2.2 grays, intermediate risk 2 grays, low risk tumor received 1.8 grays as planning target volume. So what are the complications of IMRT, and which structures should be avoided in IMRT? So if we see the IMRT treatment planning, the high priority is to be given to the spinal cord and brainstem, because they are very sensitive to the high dose of radiation. And if The high doses given to these areas, they can lead to transverse myelitis and neurological deficits can occur at the brainstem. Intermediate priority is given to the parotid gland of the contralateral side because it can lead to xerostomia. And additional structures which have to be shielded are oral cavity, larynx, and mandible because there can be acute mucositis, voice changes, and osteoradionecrosis. The proposed additional structures which should be avoided in IMRT include submandibular gland, pharyngeal constrictors, brachial plexus, and cochlea. Now coming to the brachytherapy. So brachytherapy was being used commonly in the pre-IMRT era, but now it is not so commonly used because of its complications. Indications for brachytherapy are tumors less than 5 centimeter in base of tongue, soft palate, tonsil, or vallicula may be implanted with brachytherapy. Primary implant in lesions less than 1 centimeter or exophatic lesions can be done, used in conjunction with external beam radiotherapy after 40 to 50 grays to primary and the nodes. It is also used for recurrent lesions or new lesions in the previously irradiated areas. So brachytherapy is the application of radioactive materials in close proximity to the tumors, was developed in the pre-IMRT era, pre-concurrent chemoradiotherapy era as a means to deliver the tumoricidal dose to gross tumors while minimizing dose to the mandible. The advent of improved radiotherapy planning and delivery techniques, in addition to a recognition that osteoradionecrosis secondary to brachytherapy is significantly high, has corresponded to a major decrease in the utilization of brachytherapy for oropharyngeal tumors. So in brachytherapy, typically the catheters are implanted under general anesthesia in the operating room with 2 capable physicians present to handle the unexpected events. Although low dose rate brachytherapy has previously been most common type of brachytherapy, the high dose rate and pulse dose rate techniques are becoming much more common and sometimes preferred given the ability to control dwell times and develop more customized dose distributions. High rates of local regional control has been found using the integrated treatment approach of external beam radiotherapy directed at the primary and bilateral necks followed by brachytherapy boost. But complications of brachytherapy for base of tongue tumors include osteoradionecrosis of the mandible, and high risk of complication appears to be related to the technique of implantation but may approach 30%. So when brachytherapy is planned following external beam radiotherapy, care should be taken to delineate the pre-treatment tumor extent because regression is not always uniform. Tattoos and gold seeds have been used to accomplish this. The CTV used is recommended by the European Society for Radiation Oncology to be 5 mm at minimum and more commonly 1 to 1.5 centimeter for the base of tongue tumors. The PTV is usually equal to CTV as implanted catheters move with the tumor, and catheters are typically positioned 1 to 1.5 centimeter apart. So here we can see with the help of brachytherapy for the oropharynx, it is indicated when the tumor is less than 5 centimeter in size, and we have to give a margin of more than 10 mm around the tumor, and the dose which can be given with brachytherapy is up to 45 to 50 grays. And results for base of tongue T1, T2 lesions, local control was seen in 80 to 90% of patients. With T3, T4 tumors, local control was 65 to 80%, and nodal control was 25%. For tonsillar primary tumors, with brachytherapy, T1, T2 lesions had local control 90%, and T3 lesions had 67%, and nodal control was seen in 20%. So brachytherapy guidelines have been given by American Brachytherapy Society, and they have published the guidelines for the use of HDR brachytherapy for head and neck tumors and oropharyngeal tumors in particular. Prophylactic tracheostomy is recommended whenever brachytherapy has to be given. External beam radiotherapy, doses of 45 to 60 grays, followed by an HDR brachytherapy boost of 3 to 4 grays per fraction for 6 to 10 doses, with local regional control of the implanted tumors reaching 82% to 94%. European Brachytherapy Group and ASTRO have also published joint guidelines for the use of brachytherapy for head and neck malignancies. For oropharyngeal tumors, these guidelines recommend 45 to 50 days external beam radiotherapy, followed by 25 to 30 days boost for tonsillar tumors, 30 to 35 days boost for base of tongue tumors, and total brachytherapy boost dose is fraction size dependent. Quality of life analysis comparing a combined regime of brachytherapy and external beam radiotherapy recommends that brachytherapy can be used with external beam radiotherapy to improve the quality of life. So, brachytherapy can be in the form of interstitial brachytherapy. Mass General Hospital in 2005 did use this technique in 40 cases of oropharyngeal cancers. Primary or recurrent base of tongue tumors were included, and they found that 54% were T3, T4 tumors. The median implant dose was 17.4 grays and 61 grays external RT was given, equivalent to total dose of 80 grays. 5-year overall survival was 62%, local control 78%, and 10-year local control was 70%. Organ preservation rate was 78%. Grade 3 osteoradionecrosis was seen in only 2% of the patients. So this is the flow chart for the management of oropharyngeal cancers, and it covers all the treatments which I have described just now. According to the tumor stage, we have to plan the treatment. Now coming to the toxicity of chemoradiotherapy. So although chemoradiotherapy is one of the best treatment options for oropharyngeal cancer, but it carries acute and late toxicities. Acute toxicities include fatigue, nausea, emesis, thick secretion, xerostomia, mucositis, dysphagia, odynophagia, alopecia, dermatitis, anemia, neutropenia, hoarseness, dysphagia. Late toxicity includes fibrosis, osteoradionecrosis, trismus, xerostomia, dental caries, and feeding tube dependence and neuritis. These are the NCCN guidelines for treatment of head and neck cancers, which have been published in 2017. And NCCN guidelines recommend various types of this. These are for the principles of systemic therapy. So most commonly used systemic therapy for head and neck cancers is cisplatin as category 1 drug, and it can be combined with radiotherapy as concurrent chemoradiotherapy. But for the oropharyngeal cancers, cetuximab has been recommended as category 1 for oropharynx, hypopharynx, and larynx tumors. And it has been recommended as category 2 for 2B for lip, oral cavity, ethmoid sinus, maxillary sinus, and double primary tumors. So cisplatin is one of the options in patients who cannot tolerate cisplatin due to the nephrotoxicity or due to their impaired renal functions. And the patients who have not responded to cisplatin, they can be considered for cetuximab. Cetuximab is a targeted therapy. And in this slide, we can see that for recurrent, unresectable, or metastatic head and neck cancer with no surgery or no RT option, combination therapy of cisplatin plus cetuximab for non-nasopharyngeal cancers has been recommended. Or cisplatin or carboplatin can be combined with paclitaxel and cetuximab. The other treatment options are in the form of immunotherapy with pembrolizumab and nivolumab for recurrent metastatic oropharyngeal cancer. So what is the role of targeted therapy in oropharyngeal cancers? So targeted therapy in the form of cetuximab, which is a monoclonal antibody, weekly cetuximab loading dose of 400 mg per meter square, followed by 250 mg per meter square for locoregionally advanced head and neck cancer patients has been used. The combination therapy was found to improve locoregional control, disease-free survival, and overall survival. Consideration should be given to the use of altered radiation fractionation with cetuximab because improved overall survival was seen in patients who were treated with accelerated concomitant boost and hyperfractionated radiotherapy. Now, once the treatment is completed for oropharyngeal cancer patients, what should be the follow-up? The initial follow-up after treatment of oropharyngeal cancer should be every 1 to 3 months for the first year post RT, every 2 to 4 months in the second year post RT, and every 4 to 6 months in the next 3 to 5 years. The intensity of examination within the first 2 years coincide with the likelihood of recurrence in the interval. Given that radiation to the neck commonly causes hypothyroidism, thyroid stimulating hormone TSH testing should be done in all patients who have undergone radiation therapy to rule out hypothyroidism. The follow-up imaging should be performed within the first 3 months of treatment. So what is the re-radiation protocol for locoregionally advanced recurrent tumor in the oropharynx or second primary tumor? The surgical resection is recommended if the tumor is resectable. Although this is possible only in small proportion of the recurrent tumors, following surgery in those patients with high-risk pathologic features or in those who are not surgical candidates, a second course of full-dose radiotherapy with chemotherapy has been shown to result in long-term survival in 20% of the patients. In conclusion, the oropharyngeal cancers include 10 to 20% of head and neck cancers. Squamous cell carcinoma is the most common histopathology in the oropharyngeal cancers. HPV is the most common risk factor associated with oropharyngeal carcinoma, and we should rule out HPV association by P16 immunohistochemistry in patients with oropharyngeal cancer. Transoral robotic surgery is the best surgical modality for early stage T1 and T2 oropharyngeal tumors, but it requires expertise and the expensive robotic setup. Concurrent chemoradiotherapy is the mainstay of treatment for advanced stage 3 and stage 4 oropharyngeal cancers. Thank you for patient listening.
Thank you very much, Dr. Jaimanti. Trainees, you may type your questions, your comments in the chat box. Thank you.
Thank you, sir.
Dr. Rashmi wants to see staging slide again.
Okay. Yes.
1, 2, 3, and 4. Stage 1, 2, 3, and 4. That's it.
Okay, this is T staging, tumors, primary tumor staging. This is nodal staging, and this is M staging. So this is T and M staging. Should I show it on the slideshow?
Dr. Rashmi is saying got them, ma'am. Thank you. Dr. Sonali Pandey, can you please show the initial slides before pathology?
Which slides you want to see?
Dr. Sonali. Dr. Sonali, I have given you the access to speak. You may ask a question.
Hello, good evening, ma'am. Ma'am,
Good
can
evening.
you please show the slides from starting, ma'am? Few slides I have missed from starting, ma'am, up to pathology, ma'am.
Okay.
Thank you, ma'am. Before pathology, yes, ma'am. From
Yeah, this
starting.
slide introduction. So it
Yes, ma'am.
starts from here.
From here, yes, ma'am. I'm introduction, ma'am.
And anatomy. This is the anatomy of oropharynx.
Ma'am, this is the first slide, no?
This is first slide. First slide is this one, and then introduction. It is starting from here.
Okay, ma'am. Okay, ma'am. Thank you, ma'am. And the pathology is third one, ma'am.
Yeah, no. First will be the anatomy. So anatomy has 3-4
Yes,
slides.
ma'am.
This is oropharynx. This
Yes,
shows
ma'am.
anatomy of the oropharynx. And here also this is lateral wall of oropharynx. And this is anterior wall of oropharynx.
Mm.
This is posterior wall of oropharynx. And this is lymphatic drainage showing level 2, 3, 4, 2B, 2A, 3 and 4 lymph nodes.
Okay, ma'am.
Then nerve supply of the oropharynx. Epidemiology.
Yes, ma'am.
Risk factors. These are the risk factors.
Okay, ma'am.
Then this is the HPV, human papillomavirus structure, which human HPV 16 is the most common HPV type, which causes oropharyngeal cancer.
Okay, ma'am. Thank you so much, ma'am.
There's a question from Dr. Navdeep Singh.
Thank you, ma'am.
He want to know about the staging system where they have included depth of invasion.
Okay. So that is the AJCC staging system, which has been revised in 2015, in 2017, and they have included depth of invasion. As I have not included that in my presentation, but I can discuss that. So depth of invasion has been included in the staging of oral cancers. It has primarily been modified for the oral cancer staging. If depth of invasion is less than 4 mm, so tumor remains at stage T1. If depth of invasion is between 4 to 10 mm, so tumor stage is stage T2. If depth of invasion exceeds 10 mm, then the tumor stage goes up to stage T3, irrespective of the size of the tumor. So is that okay for him?
Yeah, there are no more questions. Thank you very much, ma'am, for this presentation, and thank you very much, trainees, for joining us.
Thank you, sir. Thank you so much. Wish you all the best to all the trainees